Hello, everyone, and welcome to the American Brain Coalition webinar on MCI, our webinar series. I'm Jen French. I'm the board chair of ABC, or the American Brain Coalition. This is a really important educational webinar series on mild cognitive impairment, or MCI, which you'll hear referred to several times in this session. This is a three-part series, which is generously sponsored by ABC corporate partners Eli Lilly and ASI. We really want to give some great thanks to our steering committee who helped to put together this series. That includes the Alzheimer's Association, Cure Alzheimer's Fund, Dementia Society of America, the Lewy Body Dementia Association, the Association of Frontal Temporal Lobe Degeneration, Us Against Alzheimer's, and the LEAD Coalition. And not speaking of the LEAD Coalition, we are very thankful for Ian Creamer, who is the executive director of the LEAD Coalition, which is Leaders Engaged in Alzheimer's Disease. He has helped us formulate the programming and is moderating all three of our sessions. And I will say I'm excited for this session. It's unfortunately our last one, but I have learned so much in the previous two. And if you are interested in viewing the previous two, they are available. The recordings are available on our website. So, but please don't go and watch them now. You're here and we want to hear you to attend this webinar series. So with no further ado, I'm going to hand it over to Ian. So Ian, please take it away for our last session. Thank you.
Great. Thank you so much, Jen, and thank you to the American Brain Coalition and our sponsors. Good morning, everybody, and thank you for joining us for this important webinar series on mild cognitive impairment. And as Jen said, you're going to hear the term MCI a lot, so we'll try to limit our acronyms, but that's one we'll probably lean into a little bit. Just for background on myself as your moderator, I've worked in Alzheimer's disease and related disorders policy for about 30 years. I'm also a former care partner for my late father who lived with MCI and then with mixed etiology dementia, so multiple diseases contributing to his dementia. Throughout the last years of his life, it was a long and wonderful life, but certainly the impact of cognitive impairment took its toll on those final years. The LEAD Coalition is the uniting voice of more than 280 member and allied organizations and over 500 university-based researchers. We're all working collaboratively to reduce risk for cognitive impairment, improve detection and diagnosis, strengthen clinical and non-clinical supports to enrich the quality of life for everybody who's affected, an individual, their family, friends, coworkers, anybody in their ecosystem. And while we're doing all that, we're trying to make sure that we help advance the science to overcome Alzheimer's disease and related disorders so that there are fewer people facing these disorders and lower intensity, shorter duration, all the stuff that'll make for better outcomes for individuals and society. So welcome again, and thank you for joining us for this third and final webinar in the MCI series. Over the past two sessions, we've explored what MCI is, how it is diagnosed, and the challenges and opportunities involved in managing cognitive changes. Today, we're going to turn our attention to the future, focusing on brain health promotion across the lifespan, cognitive impairment risk reduction, innovations in clinical care and support, and what it'll take to ensure that these advances reach all communities. We're grateful to have an outstanding panel joining us for this conversation today, and I'll just briefly introduce you to each of the three panelists and then ask them to give a longer bit of background about their work and their role in this wider community addressing MCI and cognitive impairment. So our three panelists today, first, Dr. Heather Snyder, Senior Vice President of Medical and Scientific Operations at the Alzheimer's Association. Second, Catherine Patterson, Chief of Staff at Us Against Alzheimer's and Acting Chief Operating Officer. And Pam Price, Deputy Director at the Baum and Gilead. We're going to reserve time at the end of today's sessions for question and answer. I would encourage everybody in our audience, feel free to use the Q&A box in Zoom throughout today's conversation, and we'll get to as many of your questions as possible in that last roughly 15 minutes of today's program. If we can answer a few of those questions in real time in the first 45, we will certainly do that. But anything we can't respond to during this hour, unless your question is anonymous, if you've given us your name, we'll be able to follow up with you offline and try to get you the response that your question deserves. So, with no further ado, I'm going to ask each of our panelists to do a little bit deeper dive self introduction. And Heather, let's start with you, and then we'll go to Catherine and ask Pam to bring us home.
Yeah, no, happy to. And huge thank you to ABC for hosting today's discussion, for including me, for the Alzheimer's Association, and Ian, to you for moderating these three discussions. I've been watching along and really excited for the conversation with my fellow panelists today on a topic that's incredibly important, I think, to all of us, really thinking about brain health and where and how we incorporate brain health across the lifespan. So I'm one of the scientists on staff at the Alzheimer's Association, and I've been at the organization a little over 15 years, and I've really seen the evolution as we've increased our understanding of the underlying biology of what's happening during the disease course, but also as we understand really all of the diseases more and more. We understand more about all of the diseases that cause cognitive impairment and dementia, and that there is this path that we can potentially build resilience or increase our resilience to some of those brain changes before they happen potentially, or once an individual is experiencing them, how can we intervene and experience and how can we support those? At the Alzheimer's Association, one of the top questions that we've gotten for years, and I think this is probably true across all of the organizations and those that are listening in, has been my mother, my father, my aunt, my uncle, my grandmother, my sibling has cognitive impairment, has dementia, has Alzheimer's. What can I do? And we've had hints in the science. There's a huge wealth of science that's given us some hints into that. And it's really been my privilege to be a part of a lot of that work that the Alzheimer's Association has done for well over a decade. I think we published a paper in 2015, 2014, 2015 that really took a look at the different factors that were out there and what we could say with really understanding what are those hints that may be beneficial. But there was only so much that we could say. And we've really seen in the last 10 years that science has expanded so tremendously, really from the report out of the finger study in 2014, first at the Alzheimer's Association International Conference, to 2025, where we saw the larger scale US pointer trial report out looking at simultaneously targeting multiple risk factors in a population thought to be at an increased risk for cognitive impairment and seeing a benefit on cognition. This is huge. It's been my absolute privilege and pleasure to be a part of the leadership team of US Pointer from the first conversation where we sat in a room to say, is this even a study we can do in the United States? Can we do this across the communities? Can we deliver it? Can we ensure that we're reaching the communities that are most at risk? And can we do this in a way that has the sustainability and the ability for us to then take a very rigorous trial and translate it to the community? And so the trial was a labor of love, but was a very successful outcome with the positive outcomes. And we're continuing to learn from that. And now, and I know we'll talk about this a little bit more, how we're translating that going forward. So again, really looking forward to the conversation as we think about brain health and all of the science behind it going forward.
Great, thank you. And Catherine.
Heather, what a great way to kick us off. Thank you to ABC. Thank you to Ian and Lead for moderating today. I'm also really grateful to be on this panel with such great speakers. I'm really excited to hear more from each of them as well. As Ian mentioned, I'm Catherine Patterson. I'm the current acting chief operating officer at Us Against Alzheimer's. We work specifically on prevention and risk reduction, which you just heard Heather talk about beautifully, early detection and diagnosis, and that's that tight tie to mild cognitive impairment. So excited to talk a little bit more about some of our efforts there, and also access to effective treatments and care. We do this through a series of strategic convenings and then work a fair bit on policy at the federal level. So again, happy to talk a little bit more about some of the efforts on the Hill that could also help with things like early detection and also access, making sure that everybody has the ability to be screened and detected, and looking really critically at brain health, not just in our later years, but also throughout our lifespan, which is, I think, is a really exciting part of the work in the field right now. I'll just mention before turning it over to Pamela that, like many of us, I have a direct connection to the disease. My mom was diagnosed with Alzheimer's last year. It was actually last June, so we're coming up on a year. And I'll just share briefly, and we'll get into this a little bit later. I started noticing changes in 2020. 2020 was a weird year, everybody, right? There was a lot going on in 2020. But I hope one of the things we talk about is some changes that we don't always lift up when we talk about memory loss, things like behavioral changes, things like what is normal for one person may not be normal for somebody else. And so, how do you really pay attention to those signs, take them seriously, and then the benefits of early detection? We are very lucky to live in an area that has a memory clinic. We have an ADRC here in Baltimore, an Alzheimer's Disease Research Center in the form of the Hopkins Memory Center, which we're very lucky. And even so, it took 5 years to get a diagnosis. I don't think any family should have to go through that. So, what are we doing as a field to increase access, get people the information, and most importantly, have the most time possible that they need to plan and consider what they want their life to look like? So, really interested in getting into all of that with you all.
Thank you, Catherine. And Pam, over to you.
Thank you again, ABC, for having me and inviting me to participate in this really important conversation. And Ian, again, I'm always excited to have an opportunity to talk and engage with you. Ditto, I'm very excited to hear from both Catherine and Heather as well. So I'm Pamela Price. I am the Deputy Director for the Balm and Gilead, and we are a national non-governmental nonprofit organization. I also serve as the director for our Brain Health Center for African Americans. Our work sits at a very particular intersection of faith and community and then public health. And so all of our work really looks at how do we bridge um, what's happening in our community and then what's happening in science and academia and in pharma and all the amazing innovations that I know we're all very, very excited about. We're kind of opposite a little bit about Catherine's story. So a lot of the individuals who we are working with are in rural settings. They don't have that. And so imagine if it took 5 years when you're surrounded by all these amazing resources, how families and communities are having to navigate this kind of, continuum of brain health across the lifespan, but doing it in areas that are significantly limited in terms of the resources. So I love that, we've already heard things such as how do we improve access, but even the information. I was talking at a Juneteenth event and we talked about it took 2 years for that information of your freedom to get all into the things. And we see that in health, like that applies in health. Science comes, abstracts get published, publications are out there, and then it takes forever for that information to kind of trickle down to the community, even providers, so that they can make the best kind of clinical and patient, decisions. And so I'm really excited to be a part of this conversation and looking forward to hopefully again shifting this paradigm, changing the narrative when we think about brain or cognitive health, again from younger folks on up. My husband's 53 and he has MCI from after some traumatic brain injuries that he suffered. And so, again, all of this hits home for all of us. So really excited to be here.
Thank you, Pam. And let's dive into the questions. So, Heather, starting with you, but encouraging everyone to feel free to jump in. The association has been at the forefront of research into modifiable risk factors. You mentioned the U.S. Pointer study and the Worldwide Finger study. How strong is the current evidence supporting lifestyle interventions in particular? So things like exercise, sleep, nutrition, social and intellectual engagement, cardiovascular health, and obviously the list goes on. How strong is the evidence in reducing cognitive impairment risk or delaying the onset of cognitive impairment? And how does the association help translate that science, to Pam's point, into practical guidance for clinicians and the general public?
Yeah, and I think your question, Ian, is so perfectly worded because there's two components here. So what we asked and what we tested and found in US Pointer and really modeling after what the finger study had done, as well as a few other studies around the world, was looking at the impact of of targeting multiple risk factors at the same time with an intervention. So the synergy of that intervention on cognition. And we saw a benefit. We saw that individuals who were at an increased risk had a benefit on cognition, whether they were in the self-guided or the structured, but with more support and the social support, which I think becomes really important to Pamela's point, within this, the more support that they had, the bigger the impact. Now, that's not looking yet at whether we're delaying cognitive impairment. It's a little bit of a fine tune. That's not necessarily looking at whether are we preventing dementia? Have we prevented or delayed onset of mild cognitive impairment? And we don't know that. And that's why we're continuing to follow those tremendous, amazing participants. And we have had a huge number of them have continued to stay in what we call our alumni extension study, where we're able to follow them and collect annual information about their overall health, their cognition, and their continuation on the intervention. If you look at what the Sprint Mind study, for those of you that may not know, Sprint Mind was part of a large study that tested looking at lowering the systolic blood pressure. Systolic blood pressure is the blood pressure that pumps blood through our entire body. And what they found is when they lowered it compared to usual care to 120, that they actually saw a benefit when they combined looking at mild cognitive impairment and dementia over nearly a 10-year follow-up. Now, that was in individuals that they also saw after the intervention ended, they saw some deviation of that intervention. So just the window of time where they had that intervention had a benefit in terms of thinking about cognition, right, in that period of time. So we need to continue to follow these individuals and understand the impact of the intervention long term. But in the meantime, this gives us, I think, really definitive evidence that we can benefit our cognition in an at-risk population. We can benefit our cognition as we age by really looking at targeting and engaging in these behaviors, such as all the things that you named, right? Nutrition, physical exercise, medical monitoring, our heart health, our metabolic health, and bringing those things together in a way that's really going to maximize our brain health. Now, US Pointer had a very specific recipe that we're looking at, that we were testing, that we were rigorously testing, and we're doing a lot of work now. We've funded 12 teams across the country to develop plans for translating the trial to the community. And to Pamela's point, whether you're in a rural environment, or Catherine, your point, whether you're in an urban environment, there's different considerations for how you're going to deliver or how you're going to bring people or bring to the community the various components of the interventions, and making sure that that's very clear, along with the educational pieces and all of that. The recent Facts and Figures special report this past April tells us that 90% of Americans say brain health incredibly important as we age, but less than 10% know what to do about it. So we've got to think about, how do we communicate to our communities what to do about it, and how do we then make it accessible and make it available and achievable.
We're just going to add one piece
Please.
to Heather's incredible overview of those modifiable risk factors. I think it's also fascinating thinking about those potential factors that we don't always associate with cognitive health. And I think hearing is a great example of this. Being really on top of getting your hearing checked, paying attention to that, and understanding the link in being able to hear, engage fully, whether it's with your family, your loved ones, your community, at work. All of that has a profound impact on cognitive and brain health, and making sure people understand that and then are getting access to care in terms of getting their hearing checked and having an intervention that could potentially, to your point, Heather, delay the onset of dementia.
And the only thing I would add is, first of all, I think it was just amazing what came out of that. And I'm really excited about how the implementation or kind of translation of that will look in communities, because I think some of the challenges that we've seen is folks not truly understanding, well, when we say brain health, what is it? When we say MCI, all those things, but they because of, we know heart health, because we know there's been, interventions and lifestyle change behavior programs centered around heart, centered around diabetes. The community recognizes that. They know what those terms are. And so I think that's also just another kind of value add, is that it eliminates that hurdle of what the communities don't know, of trying to explain, why do I need to do this for something that I don't have, or I don't fully grasp or understand? How am I at risk for, Alzheimer's or dementia? And so I think that's also a really, really interesting, add or positive from what the evidence has been showing us.
Ian, can I add one
Yeah,
more thing
please.
just to Pamela's point? Because I completely agree. And I think with one of the things is, US Pointer is one particular study, right? That tested one thing. But I mentioned at the very beginning, there's a wealth of data and information that really has informed our understanding of all of these individual risk factors. And increasingly now we're looking at this combination of things. And so the Centers for Disease Control and Prevention has funded, three different centers of excellence, including one on risk and understanding risk. And really a lot of the tools and resources that are then distributed really through public health agencies and made available into communities. Pamela, all of the areas that you've mentioned really come through the Bold Center and through the state public health agencies. And I think that model is really, that's the foundation of what we're laying to say, here's what we need to understand. And then we need to build on it across the board. And so that wealth of science, we don't want to forget about that wealth of science. I'm obviously biased. Pointer, I think it's an amazing study. I'm part of it, but but it's also the wealth of the science that it's based on and continues to go forward, which I think is incredibly important for us to think about as we're having all of these conversations.
Yeah.
It's really, really helpful. And I just want to throw in a follow-up. So I'm a layperson. I'm not a scientist. I'm not a health professional. I'm not a public health professional. I'm not a lot of things. But so Heather, you mentioned as one other example of an important study, Sprint Mind study around hypertension, aggressive management of hypertension, and the clarity of that evidence. If I understand correctly, but please correct me if I'm wrong, that's something that's ready today. Clinicians should right now should be relying on that evidence to say to their patients, let's make sure we're looking out for hypertension, preventing it, and if you've got it, managing it aggressively, not only because of the cardiovascular health issues, but this also, the evidence is clear, solid, reliable, actionable. Let's do this for your brain health too. Is that roughly right, that it's ready today?
Yes and no. I mean, there are some considerations that I think need to be incorporated, and there have been new guidelines that, in terms of clinical practice guidelines that have come out around managing blood pressure more recently. I think what I would say is, Sprint Mind was done over a long period of time, and it was over 10 years ago. And our understanding of this continuum of cognition, so the MCI to dementia, we talk about these as two separate things, but really it's a continuum, right? You don't just wake up one day and have mild cognitive impairment. You don't wake up one day and have dementia. You've had these changes. Catherine talked a little bit about some of the changes she noticed earlier, right? Which may not have been detectable on some of the tests that we have that are available. And it's really that continuous that continuum that I think we increasingly understand. And so when Sprint Mind was initially conducted, they did not adjudicate, meaning they didn't look for cognitive change at the very beginning. So they were looking from a change from the beginning of the trial and on. So there's some, there's how that translates in across the board in terms of clinical practice. But the new guidelines do recommend the adjustment in terms of managing blood pressure across the board. And that's really for overall health. And I think our knowledge that this impacts brain health is key too.
Right. So I appreciate that point in particular. A, thank you for educating me. and B, just this idea that all of these things, Catherine's point about getting assessed for hearing, and then if you need hearing aids or some other sort of support, do it and do it with fidelity. Whether it's that, diabetes that Pam mentioned, better sleep, which I imagine almost all of us could improve on, nutrition, et cetera. Those are things that are going to improve your overall health and hopefully, as part of that, your cognitive health. But at bare minimum, and I know this will be a little bit of a crass way of putting it, if you wind up with cognitive impairment, are you better off having just cognitive impairment or cognitive impairment plus, I'll pick on diabetes? Clearly, you're better off having just one condition rather than two. So if we attack diabetes and the evidence proves out that that reduces your risk or delays the onset of cognitive impairment, great, that's fabulous. But we ought to be doing those things anyway, wherever the evidence winds up. Your quality of life will be better around the diabetes symptoms, but also around managing whatever cognitive impairment may come your way. Is that a fair way? I'll open this to any of the three of you. Is that a fair way to present it to individuals, clinicians, the broader public?
I do. I agree actually wholeheartedly. Actually, I had scribbled a note down similar to that effect, Ian, is that even if we think COVID, COVID exposed our inability to prevent anything. And so I think, like you said, the science behind hypertension, diabetes, these chronic, vascular related health conditions, we have always had not only the science to say what the consequences of not managing, what the consequences are of actually having individuals diagnosed with these conditions. We've already had that. We've also already had interventions that data has showed us if we can do this, if we can change and modify this, we can prevent type 2 diabetes from ever occurring. We can prevent individuals from developing hypertension. So I think you really hit it. Now that we also have this added benefit that science is telling us we can also improve, or potentially improve our cognitive health. I That to me just really means that we're now not talking about barriers to dementia care or barriers to Alzheimer's, we are talking about barriers to just simply accessing healthcare that will then allow individuals to not have, like you said, to not have so many comorbidities that we know ultimately it's hard to try and balance the A1C with a blood pressure, and then the barriers that then come with how do you access healthy fruits and vegetables? How do you access safe spaces to actually go and get your physical activity? So all of those things are connected, and I think you take us further down the stream in this conversation around cognitive health that I think is really, really important.
So, Pam, if I could pick up on a point that you've made in a couple of different ways. We know a lot of what we need to do on brain health happens outside a purely clinical, doctor's office kind of context. Can you share with us, just based on your organization's experience, your individual experience, maybe something about the role of community-based organizations? Those could be faith-based, it could be civic organizations, local networks, community leaders. What are those roles like, and how can they be more effective in conveying some of this brain health, cognitive impairment, risk reduction information that we want to get to all communities?
Yeah. I think they play a very critical role in this. They are a untapped or an often untapped workforce, if we want to look at it that way, because these individuals, one, they're here 24/7, 365 in community and whatever the community looks like. What we've done is to find those individuals, identify them, and equip them with the same information that you and I have. Equip them with the science, breaking down what we pull, what we see at the big major conferences. I'm always coming back and saying, I want to take that, make that in a plain language summary, and give this back to the community so they can see what the data and science is saying, and then work with them to say, how could your community, how could your church, how could your community center, how could your women's group, your men's group, how could they take this science, take this a program? We have lifestyle change programs. We went from a 12-month to saying, hey, let's adapt it and make it a 6 weeks. And we still seeing the good evidence. And even Heather hit on it. It is the community support that is what makes the difference. Individuals we've seen it, have the greatest success in dropping weight and maintaining the healthy behaviors when it's done in and through communities. And so I don't think we can do this work without having a built-in community infrastructure to actually drive whatever it is that we want to build based on what the science is telling us right now.
And I would love to add to Pamela's
Let's
absolutely spot on point. I think this is where community level interventions marry so well with public health. Because when I think about public health, I think about seatbelts. I think about water fluoridation. I think about true sanitation, clean water, access to clean water. When we are able to build that partnership, an effective, true partnership that has reciprocity between a community and public health agencies, that's where we see real movement. And I think about Tom Frieden, who's a former CDC director. used the phrase making the healthy choice the easy choice. We have made the unhealthy choice the easy choice. It is so easy. Let's think about just driving somewhere and going through fast food. We have made that easy. Why are we not making it easy to eat well, to exercise easily? These are all things that are possible. They do require resources, and they have to require that authentic relationship between community members and public health interventions.
So, Tammy, made me think about another follow-up, and so I'll just start with you, but this is certainly open to all three. If we can get people to think about brain health in all their environments, not just when they're at the doctor's office, if we take this more community-based approach where it's more holistic, does that help normalize conversations about what brain health is and what might be maybe indicators of a concern about cognitive health that can then be translated into people being more willing and maybe being more aware of how to have those conversations with their healthcare providers to get detection and diagnosis where necessary, or to alleviate their concerns about maybe an underlying disease like Alzheimer's and find out that it's something more easily addressed and potentially corrected.
Yes. So like we've seen that just as recently as just this year. So we've been going to community spaces in our churches and other places doing health forums, after, a certain Sunday service or a part of some community event. And yet we see exactly that. Like individuals, then, we hear, okay, well, now I know to go to talk to my doctor. They also, to Catherine's point, they now realize what they potentially saw but didn't realize I should probably pay attention to that. I think even when we talk and to them about the new biomarker, new testing and new innovations that we have, they're excited about that as well. And it gives them not entitlement and really not even empowerment, because I really hate that word, but it really gives them permission perhaps to say, I now know how to go and advocate. I know now it actually strengthens that kind of patient provider shared decision making, where I think sometimes the patient does not have everything that the clinician has. And so it makes that shared decision making kind of unbalanced. And when we can kind of build out this education that's really, equipping individuals exactly where they are, we're connecting them to organizations, support services, folks right there in their communities, it actually does normalize conversations around brain health. I think about when we first started our center in 2016 to like now when we do our Memory Sunday campaigns, I don't have to do a lot of the education that I once used to do. We hear directly from the community that 89% of them now, after participating in an event or forum, say they now feel comfortable being able to go and ask for a memory screening or being able to go and to talk with someone else, a loved one, about it. So it definitely does boost the readiness. It primes the community to be able to now go back into our health systems, and to know what to ask for and what to advocate for. So yeah.
Maybe can I just build off of Pamela's
Please.
comments, is one of the things that I think we also learned in the special report this year is that individuals are incredibly motivated. They want this information. They want to have this knowledge, right? And so Pamela, all the things that you noted is you hear things and how do you get that to the community? And I think it's, you hit on it. It's not one way. It's lots of different ways to really reach all corners of the community. And one community is very different from another community in how you may reach or how you may share that information. But of those individuals, they want to have this conversation. They also really want to have this conversation with their doctor. They want to have it with their healthcare professional, right? Or with their provider, whoever that might be, whether in their community. And so I think it's on all of us to also bring forward and make sure that our healthcare providers have that information and really feel that they're able to have those conversations and bring it in. And it doesn't need to necessarily be only their PCP or a specialist. It could be any of their doctors, right? It could be their the person that's taking their blood pressure at the local health, but that it needs to be part of that conversation. And I think we've seen an uptick in terms of brain health and the conversation and the dialogue, but also many people said that they wanted it. They wanted to start thinking about this in midlife, and midlife makes sense, right? We start asking about our cholesterol. We start asking about our blood pressure, our H1C in midlife. This is me, right? I'm asking these questions of my doctor. I'm going and trying to track these and follow them. And how do I bring in asking about my brain health? What should that look like? And I think the science is getting us there, and we're all laying all the foundation that's really putting us in a place that we'll see that. And I think we'll see that really evolve in the next, I'd even say we'll see an evolution in the next year, the next 5 years, and even the next 10 years.
Terrific. So, Catherine, want to ask you to kick off the next, responding to the next question. And I'm thinking about both your public health experience and your role supporting your mom as she sought a diagnosis and now that she has one. I'm wondering if you could speak a bit to some of the maybe barriers, but maybe also untapped possibilities and opportunities around how we translate information about brain health and maybe warning signs of cognitive concern. How do we translate that from what research tells us to what people experience in their daily lives and make it practical and tangible for people based on their lived experience and to the point you've all made beautifully, very different lived experiences for so many people in this enormous, complex, diverse country?
Really appreciate that question. And I think the challenge is, or maybe the challenge and opportunity, this is an exciting time. Pamela mentioned new diagnostic interventions like biomarkers, whether it's a blood-based biomarkers or others. Heather has talked about the growing evidence around risk reduction and prevention, which continues to come out. And there's also new treatments, thinking about what's in the clinical pipeline. But what works clinically and what is cutting edge clinically, there's always an implementation gap. And that's where I still see a lot of systemic barriers. We currently have a very fragmented system, and you need an individual who, or somebody who is willing to partner with an individual who has a degree of fortitude, because this is a long journey in terms of both starting the conversation with, as we've talked about, normalizing conversations around brain health with all of your providers, but also seeing it through the diagnostic pathway and then thinking about treatment and care. That's a place where I feel like the science is strong and the translation needs to get better. We have health system preparedness issues. We definitely need to do a better job in educating providers, all types of providers, as Heather mentioned. But we also need help in terms of helping individuals and their families navigate this. So I just think anecdotally, I had to start attending doctor's appointments with my mom's primary care provider because I was not hearing any of what was being talked about, said, or needed to be followed up on. And so that became part of just our regular routine. I would take my mom to the doctor. I would follow through with conversations. And eventually I took over things like medication management. We've talked about managing multiple chronic illnesses. If you have cognitive impairment, that becomes issue number one, because if you are not managing your other conditions, you are quickly going to find yourself in an emergency room setting, which is terrible, particularly for somebody with mild cognitive impairment or dementia. I think there's also a challenge, depending upon where you are, of understanding which agency provides which service. And that differs depending upon where you live. Pamela has talked really compellingly about the role of community-based organizations, which are a critical component of this journey. But if you don't know who is doing what, it takes a significant amount of effort to get that information and then get your the person that you love or the person that you're on this journey with to be plugged into that. One of the things that I find a real challenge with is having a clinician give great recommendations. I'll give an example of, I had a wonderful neurologist who said to my mom, "You would really benefit from a memory cafe. That would be a great place for you to go, and maybe for your daughter to go with you, and you could access people who are living with dementia and talk about what is challenging for you, and then what do you really want to, put your purpose and passion into." And that was a great recommendation. My mom does not drive. And so there is an issue around transportation. My mom's executive functioning is really not high right now. So even identifying a memory cafe to go to, that was a great suggestion. If there's no support, that follows along that intervention, it doesn't happen. And that's where I feel like we are not doing our best in terms of getting the best outcomes for individuals and for their families if you make the recommendation and don't have a plan or an idea around how to implement it. So that's a piece that I feel like we still have a lot of work to do.
This inspires me to do a shameless plug. I used to work at the Alzheimer's Association forever ago. First 15 years of my career, I worked for a local chapter. And I was not the person that was working directly with families around care and support. The helpline staff did a magnificent job, and I was privileged to at least hear some of their stories about what made their recommendations practical or impractical. But part of what I loved is they took the time, and I know this still to be true on a nationwide basis, the Alzheimer's Association helpline and other organizations that take the time to ask questions, not just to give recommendations in kind of a rote way, but ask questions to understand what's practical and what collateral supports might be necessary to operationalize. And so, Heather, I think I have the helpline number memorized, but I'm going to rely on you to get it right. I will just say it's 24/7, 365. You get a live human being who's trained and expert, not just someone who's, answered an ad in the help in the newspaper. And it's available, I think it's over 140 languages. So as we also think about different domains of disparate impact and disparate access, language barriers are enormous. And that's one of the many things that the Alzheimer's Association, among other organizations, really helps knock down by having these either multilingual staff or embedded translation services. So Heather, could you just do a quick plug of the 800 number so that I don't butcher it?
Yeah, it's 1-800-272-3900. But if you didn't write it down real quick, you can also just go to alz.org and it's on every single page. But 1-800-272-3900.
Terrific. Thank you. I actually had it right, but I was just too afraid to speak up. I thought I'd get a digit wrong.
To be fair, Ian, I double checked myself when you said it because I'm like, now you're putting me on the spot.
So this is a cognitive test in real time, everybody. Just like test your recall. If you've never been good with names and you're not good at names at 85, that is not a warning sign of cognitive impairment. But if there are skills you used to have and you're seeing significant change over time, that's a good reason for a conversation with a health professional or a trusted expert in the community. So thank you all for indulging that shameless plug of an organization where I'm an alum. Pam, I want to ask you to kick off this next section, but would encourage all three of you to weigh in, and we will get to audience questions in just a moment. But we all, I think, are very much aware and deeply concerned by the disparate impacts on various communities for Alzheimer's disease and other disorders. For Alzheimer's in particular, we know that women are at twice the lifetime risk compared to men. People of color, African Americans, roughly 1.5, I think it's, again, I'm going to ask my colleagues to correct me. I think it's twice as likely as Caucasians to get Alzheimer's disease. Latinos, Hispanics, about 1.5 times as likely. People in rural communities, going back to an early point that you made, Pam, people in rural communities are at higher risk than people in non-rural communities. So as we think about addressing this in risk reduction, detection and diagnosis, better clinical and non-clinical care, even opportunities to participate in research, what can we all be doing? Public health organizations, clinicians, community-based organizations to provide more equity, to make sure that people not only are aware of, but have access to all this array of things that will enrich their quality of life and hopefully reduce their risk for cognitive impairment or give them an easier journey if they actually develop cognitive impairment.
Yeah. I think is, and it's not simple. It's hard to do. Even Catherine just kind of, touched on that. But I really think it is being more intentional when we say patient-centered care. And we just haven't done that well enough. And I think that's where we have to start. And the interesting thing is that even as Catherine was talking, I kept thinking about other disease states and spaces, like HIV, for example. There is at least a program that I was a part of, individuals brand newly diagnosed had not only a case manager who was typically a licensed social worker, they actually had someone from the community. They just literally had just a community navigator, similar to like a community healthcare worker that we utilize today, who walked with them every step of the way, how to apply for whatever programs and services, how to actually apply for copay assistance programs once they knew they needed therapy, how to, addressing transport, like an individual from the community did a needs assessment from the patient, not something we did in our EHRs, not something, and that was very critical. Like we shortened the time for individuals from newly diagnosed to actually getting their first visit with the patient. We shortened it by over 60% in terms of it was taking months, if not longer, to get individuals into care versus once we added that component of an individual that walked with them, they were getting into care within a couple of weeks. And so I think there are lessons to learn from other disease states that we can then apply. And then now just say, not let's wait till there's the diagnosis of dementia. We need to look, further down or earlier on and say, what can I replicate? How can we scale? We tout, I'm like you, Ian, we also tout the 1-800 number for the Alzheimer's Association because it is so valuable. We just add someone from the church who says, hey, I'm going to be with you when you make that call. We're on this call together. And so as they're talking and they're giving you again all the recommendations or places that you can go, we now have a list together, and you have someone who now once I've got off the line, I have a really good plan. I have someone to help me execute the plan. And I think that's what's missing, and that adds to the burden of our caregivers. And so it's really looking at this kind of community linkage infrastructure that if we can work to really build and that out, I think that helps move us to have better implementation and better translation with the evidence that we have. And we've seen it be successful in other spaces. So I really don't see why it wouldn't be successful in the brain and cognitive health space.
Pamela makes such a good point about having that person come right along with the individual. And you're absolutely right. We do this in other disease spaces. It also makes me think about the GUIDE program, which is not available currently everywhere, but truly is an amazing resource if you have it in your community, if you're one of the many pilot sites where you can have access to a licensed clinical social worker who is in the community, who understands the support systems within that locality, and then is available 24/7 for individuals who have been diagnosed with a form of dementia, which is really powerful. The other thing I was going to add in terms of access, one of the things that Us Against Alzheimer's is currently doing is we have a resource called My Brain Guide. It is a fast, free, anonymous way of kind of getting a baseline on cognition. And one thing that we've just introduced is a connection to a telehealth provider who could connect you with a neurologist, thinking about those real gaps in getting access to care, the incredible wait times that folks currently experience when they have been referred to a neurologist, to a specialized neurologist. As Pam mentioned, just really trying to shrink that timeline, get people into care faster and have better outcomes. I think that's a critical way of expanding access and making sure that everybody who is seeking care is able to get care, which is a big part of our focus around equity and making sure that that is available to everyone.
And maybe just to build off of Catherine's points, I'm not sure how many of those that are listening in or are here. One of the things that I think has been a legislative priority of the Alzheimer's Association, and we've had incredible champions recently, is really building off of that. Is how do we make sure that there is access when the science is ready and when things are ready? And so the Alzheimer's Screening and Prevention Act, otherwise known as ASAP, really looks to bringing in that legislation that then gives the authority for making coverage decisions when it's deemed appropriate in terms of those tools that for screening, for diagnosis, to really allow people in all communities to have that access. People want these resources. We've all just talked about all the benefits of early detection and diagnosis. And as we understand more and more about the science, and as we move back in time and being able to identify potentially that in people without symptoms and intervene at those points, we need to have the tools and we need to have coverage available. And we need to make sure that people have access. So really exciting work in terms of that, and an opportunity as we really lay that foundation for the future.
Great. Heather, I appreciate you bringing up the ASAP Act, and it picks up on a question that has come in. So the ASAP Act, as I understand it, and correct me if I get this wrong, it's focused on blood biomarkers that would tell us whether the biological or pathological markers of Alzheimer's disease or a related neurocognitive condition, frontotemporal dementia, Lewy body, et cetera. If the biomarkers are there and the test picks it up, making sure that those tests that are FDA approved would be covered by Medicare. Is that roughly right?
It gives the authority to the Centers for Medicare and Medicaid Services once a test is FDA cleared for a given population to cover, not requiring necessarily the many, many years, right, of all of the studies that need to happen. So if there is a need, if FDA has cleared a test for a given population, it would give the authority to CMS for coverage across the board. So it really uses the existing rules that are available and then gives that authority to CMS. I hope I'm using the right word.
Yeah, so it doesn't mandate that CMS cover it. It gives them the authority to cover it based on the science. And it doesn't mandate that clinicians use it or that patients get tested. It's just creating a pathway to availability. Got it. And then another policy initiative, which is not around screening, but it's around detection and diagnosis. I know Us Against Alzheimer's has led the charge for a piece of legislation called the Change Act. And Catherine, I wonder if you could just give our audience a basic understanding of what the Change Act would do.
I'm so glad you brought that up. CHANGE, which stands for Concentrating on High Value Alzheimer's Needs to Get to an End Act, just a slight mouthful, would use Medicare annual wellness visits to screen for Alzheimer's, and would require that the tool that is used that has been basically validated, and that it is a true validated test that can be available for everybody. Again, providing that baseline for those folks who are receiving Medicare and are doing their annual wellness visit. It could be a great opportunity for everybody to have greater access to that effective screening so that they can make choices about where they want to go in terms of treatment, or even things like access to clinical trials if they might want to enroll in a clinical trial.
So, Pam, if I could go to you with a follow-up. The data is pretty clear. Women get diagnosed later than men. People of color get diagnosed later than Caucasians. And later in terms of delay, not in terms of symptoms emerge later, like the symptoms were there, but clinicians maybe are missing it. And we know that very well-intentioned, very well-trained clinicians, if they're relying on what, as a layperson, I would call the eye test, that they don't spot things as early as they could. And I wonder if you could speak about this issue, particularly through the prism of health equity and that greater chance that symptoms that should be recognized, if we aren't using, to Catherine's point, validated testing instruments, that we might be reinforcing those disparities, particularly for women, people of color, people in under-resourced healthcare environments.
I think that goes to a couple of things. Some I know we really can't touch on this conversation, and that is just really how the healthcare system is structured and the amount of time patients, providers, and clinicians even have. But I won't go there because that is an issue. We've seen it and we've heard it when we've gone in to do trainings with clinicians. But what we've also heard from clinicians is that there is a hesitancy, even when there is a consideration from them of what they're seeing. And some of it touches on because there's already so much that this patient is involved with that they are actually hesitant to go down this route of, do I need to add something such as a cognitive health issue or, God forbid, dementia? So there are some attitudes, I think, that we, perceptions that we also need to figure out, how do we support clinicians in that way. I also think that we look at when we look at the relationship, like here in Virginia, we just passed a bill that requires really intentional implicit bias training for clinicians, and we don't have that everywhere. Because I think that is this, like you said, it's I'm here and you're having this clinical look of an individual, but you're also at the same time perhaps making assumptions and or decisions, and you withheld certain information. You may even withheld certain offering of screening and testing just because of it. It's been baked in. You've seen it. It may be just a part of the culture within our health organizations, and I think providing the right types of trainings to clinicians so that those blind spots can kind of be removed goes a long way with making sure that we can close the gaps on these disparities that we see. And then just further down the pipeline, I think, is making sure that these communities also are just accessing regular annual screenings. We saw in COVID that we took a snapshot of individuals who we were participating in our diabetes program, and over 80% of them had not seen any type of healthcare provider in well over a year for anything. And so that also adds to the disparities of, and then getting into the why. Some of it because there's no provider here, some of it is because cost and things like that. But I think if we look at, to Catherine's point, what are some of the stop gaps we can put in place with that maybe can be in the community to be placeholders. We could maybe start doing those lifestyle change interventions with the individual while they're waiting to maybe get reconnected or get engaged with our healthcare system.
Excellent. So I wish we weren't running out of time, but we are. And I want to make sure you each have an opportunity. Maybe take a minute. I know we could do an hour, but take a minute maybe to talk about something from your perspective, individually or organizationally, that really gives you hope about advancing brain health and risk reduction, or decreasing stigma around cognitive well-being, or addressing some of the systemic challenges in public health, clinical care. You can take it in any direction you like, but Heather, why don't we start with you?
Yeah, so I mean, I'll go to where I started maybe at the very beginning, the science. I'm a scientist by background. The science is there. The science continues to grow. The science continues to evolve and increase our understanding of all of these aspects, including the evidence in supporting the community-based research engagement and how to best do that, and really giving kind of the roadmaps for how to do that in a way that maybe researchers haven't always been very good at. And so I think the science is what gives me hope across the board. The community that we have in engaging and and I think the real commitment that across the board, that everybody, many of us have been personally affected either today or will be. And so that commitment to changing and really embracing the science and putting it into
Beautiful. Catherine, to you.
I'll say my excitement is really twofold. One is this broad adoption and greater understanding around the importance of brain health across someone's life, really starting in infancy, having a greater focus and more knowledge across the both for healthcare providers but also for individuals. Really understanding, I have one brain, I have to protect it. These are all these different interventions that could protect my brain over the course of my life, and then getting that into a systematic way of caring for our brains, I think is really, really exciting. The other thing I'll pick up on is it has been a challenge over the past couple of years to really, from a federal side, buoying support for particularly Alzheimer's and related dementia. And we have seen policymakers step up. I find that incredibly powerful. We need to continue to sustain those champions and also continue to build champions.
Terrific. And Pam, bring us home, please.
So
What gives you
just
hope?
Ditto to everything both Heather and Catherine said. And I think yes, I'm excited too about the science. I'm very excited about the innovation, both in therapies, both in testing and diagnostics. What I'm hopeful for is that because there is a growing demand in our communities that we are seeing, that they are demanding not to be left behind. They are demanding to say, if it's new therapies and an early diagnosis is the window, I want to make sure that I'm getting the early diagnosis. And I love that. I'm again considering, like I said, remember some of our first brain health town halls and how those conversations look compared to how they are now when we go out into the communities. So I'm really excited about that. What I want to see, though, is I think the same way that science is innovating in diagnostics and in therapies, I want us to also get more innovative in the actual implementation. Let's get innovative in the actual delivery of of what we know we can do. I think that that's where we drop off. We get really excited. The new thing comes out, and the folks who need it most don't get it because we were not as excited about bringing this new tool or this new instrument as we were of saying, now I just need to also make sure what are some new ways. I know someone mentioned about HBCU student ambassadors. There are amazing programs. The CDC, I'm proud to be a part of their lifestyle change intervention research network. They're really looking at all these interventions that we know have worked. How do we now make a huge dashboard that someone can come in and say, I want to try and implement that and see what can happen in my community and how I can improve health. So I think this is just a very, very exciting time and really just I'm humbled to be just a part of all of this great work.
Beautiful. Well, I will just add, all of you give me hope. The organizations represented in these three webinars, but even more important, our audience. You've tuned in for this. This matters to you and the people that you work with, care for, support, serve, those you love in your family and your community. Keep doing that. Keep being ambassadors for these messages of hope and opportunity, and reaching everybody in need, whether their need is because they are at risk or living with cognitive impairment. We can help everybody if we reach them in a way that destigmatizes and normalizes conversations about brain health. So I want to thank all of you in the audience for joining us today. I particularly want to thank our speakers today, Heather, Catherine, and Pam, and those from our previous two sessions. On behalf of the American Brain Coalition and our partners, thank you for joining us for this series and for all the work you do. We hope these conversations have provided valuable insights into mild cognitive impairment, brain health, and the opportunities ahead to improve care, prevention, and quality of life for individuals and families. We'll get the recordings for all three of these posted and circulated to everyone soon. Wish everyone well, and thank you again.